Welcome to Ask Dr. Mingle, the Q&A series from Mingle Health answering your questions about quality programs and the transition to value-based care. I'm Kyle Breckel. I'm a digital marketing specialist here at Mingle Health, and I'll be hosting this episode along with Dr. Dan Mingle, founder and CEO of Mingle Health. Good morning, Dr. Mingle.
Good morning, Kyle, and good day to all of you tuning in. It's great to see you again. I'm Dr. Dan Mingle, and I'm here to answer your questions to the best of my ability.
So we have two great questions for you today, Dr. Mingle, about Medicare CQMs and MIPS CQMs, so let's just jump right into them. Our first question today comes from Carrin, and Carrin asks, are you able to tell us the year that MIPS CQMs sunset and eCQMs will be the mandatory reporting method?
Great question, Carrin. There is as yet no published plan or time frame set for a sunset of MIPS CQMs. Now, many people are drawing an inference from Medicare's published digital quality strategy that there will be a sunset and a complete switch to eCQMs. I think that switchover is unlikely. More likely, requirements of both methods will evolve in a converging pathway, possibly ending in a single type of measure, not completely like any of the current methods. Now, I don't think that expertise today in either eCQMs or MIPS CQMs is more likely than the other to prepare you for what measure type or types are supported 5, 10, or 20 years from now. MIPS CQMs are deeply embedded today in Medicare's quality payment program. It will not be a trivial exercise to end them. More likely, they will not end, only, as I said before, evolve. MIPS CQMs are necessary today to MVPs, and there's a 10-year ramp-up planned for MVPs. Now, perusal of the MVP measure choices shows that MIPS CQMs are pivotal to the MVP infrastructure as it exists today. And there's a massive amount of work represented if we want to re-engineer MIPS CQMs to the eCQM style. Also, MIPS CQMs are required for those without EHRs. They can't use eCQMs. There is no sign that the exemptions that exist for small practices, non-patient facing practices, facility-based providers is going to go away anytime soon. And until it does, MIPS CQMs are a requirement. There's a lot of effort put into creating and maintaining specifications for these measures. The disseminated network that builds and maintains measures are still doing it more actively for MIPS CQMs than for eCQMs. There are only 42 eCQMs, and they've been fairly stable over the years, and there's 172 MIPS CQMs today that continue to dynamically change every year. It will not be a trivial matter to redirect that effort. Let's look at other changes from Medicare in our experience. Medicare announced in 2013 that claim measures would sunset. They have not yet. In 2020, Medicare announced the expected sunset of web interface reporting. Now, that is finally sunsetting, but not until several years after they initially suggested it. It will sunset in the first quarter of 2025 after we build our last web interface submissions for the 2024 performance year. Now, my advice to you is to choose what is best for you today. Change if and when you need to. Now, you should have your own digital strategy. Such a strategy will prepare you for any future that I can conceive of in quality measurement. Work on your systems, particularly digital systems, to improve the quality of your care, document your high quality care, and accurately measure and report on your high quality care. The things you learn, the skills you improve, the systems you develop will be applicable to any method of reporting that Medicare supports or demands today or in the future. Choose your reporting method based on what is available, achievable, and makes you competitive today. If you spend money on an attempt to predict Medicare's future decisions, you risk wasting time and money and risk underperforming in your quality measurement efforts. I suggest do what works and change it if and when you have to. Thanks. Good luck with your reporting.
Thank you, Corinne, for the great question. And our second and final question for you today, Dr. Mingle, comes from Laura. So Laura asks, we are an ACO switching from the web interface to the APM performance pathway, the APP. We are planning to use the new Medicare CQMs. Is it required that we use the patient list that Medicare provides as our denominator?
Great question, Laura. As you're aware, Medicare introduced the new Medicare CQMs collection type in rulemaking for 2024. The collection type is meant to ease accountable care organization conversion from the web interface to full-on APM reporting, APM performance pathway reporting, the APP. Key to a successful APP submission is identification and deduplication of patients across all practices in your ACO. As part of the Medicare CQM offer, Medicare also offers to give each ACO a list from Medicare data of all patients in the ACO eligible for Medicare CQMs. The list from Medicare will be absolutely correct. It's what I call the gold standard because they naturally hold a complete and deduplicated data set as an essential part of the healthcare payment system through Medicare, the world's biggest insurance company for healthcare, that is. Now, I'm seeing two crucial pieces of misinformation circulating about Medicare CQMs. First, that you have to use Medicare's generated patient lists. You don't. And second, that it includes attributed patients that haven't been seen. It doesn't. A big part of the problem is the unusually vague and misleading provider-facing collateral from Medicare on this subject. Over the years, I've watched Medicare dramatically improve the quality and clarity of guidance documents prepared for quality payment program participants. This documentation for Medicare CQMs is not yet up to Medicare's new standards of clarity. You need to have a deep knowledge from a variety of sources to truly understand the Medicare CQM requirements and options. Those important sources, in my estimation, first, Medicare rules. Second, Medicare CQM measure specifications. And third, Medicare's topical guidance document called the 2024 SSP ACO Medicare CQM checklist. Oh, there's a mouthful. Now, first, let's look at those one at a time. First, the rules. In rulemaking annually, the rules end up in the Electronic Code of Federal Regulations at ecfr.gov. This particular topic is addressed at section 425.20 definitions. In the Electronic Code of Federal Regulations, the official home of the historic and current rule set, Medicare CQMs are defined at section 425.20 definitions, beneficiary eligible for Medicare CQMs. The language is dense, so I'm not going to read it to you here, but it boils down to two parts. One, Medicare Part B patients who have been seen by an ACO primary care provider in the performance year, whether attributed to the ACO or not. Two, Medicare Part B patients who have been attributed to the ACO, whether they have been seen or not. Now, this clearly describes Medicare's intent with Medicare CQMs, and taken at full face value suggests that you have to use Medicare's patient list because it's the only source of patients who have been attributed but not seen. That status can only be achieved through prospective alignment by patients who choose your providers as primary but never had a need or desire to see one of your providers. On the face of it, that's an important detail, but it's modified when you consider the next source, the measure specs. In January, Medicare published measure specifications in the usual form and format specifically for the three APP measures, labeling them as specifications for Medicare CQM. Now, the specs are incomplete. Other than labeling each of them as Medicare CQM specs, they are word-for-word duplicates of the MIPS CQM specs. I'd like them to mention that the denominator is restricted to Medicare Part B patients. We know that it is from the rules, but it's not brought out in the specs. The important factor the specs bring in is that the denominator is limited to patients seen at least once during the performance year. This factor in the specifications eliminates the attributed but not seen patients from the calculations, which is good news. It's going to lift your scores because you can't have data about patients you haven't seen, and we know that in an electronic form of submission, that lowers your scores. That brings us to the final document. In my search of the QPP resource library, I found one summary document on Medicare CQMs. It's called the 2024 SSP ACO Medicare CQM checklist. The document focuses exclusively on the Medicare provided eligible patient list. To the casual observer, it suggests that you must use Medicare's provided lists. It's only detailed knowledge of the final rule and the Code of Federal Regulations and a history with Medicare verbiage that we know otherwise. One word in one sentence is the key in that document. The last sentence of the first paragraph introduces the document as this resource provides steps that ACOs may take, the key word being may, to prepare for and successfully complete quality reporting via the Medicare CQM collection type. It takes some experience with Medicare specs to understand that Medicare takes the words may, should, and shall extremely seriously. May means it's not mandatory, it's something you can use. I think it's a great resource and will provide value and support for the ACO that has given up on electronic reporting and retreated to a manual chart abstraction collection type for the new APP reporting. But there are two reasons the rest of you should not use this resource. First, it's late. Medicare is usually more than a quarter behind with their release of claims relevant data. They pledge to be better with these patient lists, but the complete and final list will not be available until February after the close of the performance year, leaving precious little time to pull a complete submission together using it. Now, it's the best thing to use if you're going to manually abstract charts across your whole organization. If it's a mixed environment, you better use a more timely data source. And if you're using their list, you better abstract the charts quarterly, as these quarterly lists are provided each 2 months after the end of the quarter. So you're not left with little more than the month of March to create your entire submission. Now, though I would describe the Medicare patient list as the gold standard for your eligible patients, it adds more confusion rather than help in the typical project. Now, our favorite place to get denominator data is from claims. And we find that claims are nearly always accessible by even small practices as a byproduct to the claim submission process. We use what's called 837 files, which is your pre-adjudicated claim, what you submit to Medicare before they process it and object to some things, and you've cleaned things up. It's the fastest available, and it's very accurate. Now, we observe that data sets always vary from each other, and patient identification is the key and is the main chore in this. Every data set differs. There's spelling errors. There's formatting differences. No errors, just differences in dealing with the syntax, with the use of maiden versus married name, name changes in marriage and divorce, and other legal name changes. There's variations in dealing with middle names or initials, common use of the middle name instead of the first name, nicknames versus full name, use of numbers like the third or junior or senior, and those kinds of things. And that makes dealing with deduplication tedious and delicate. Medicare's list may be the gold standard, but it is from the ground level just one more list that differs from all of the others. So if we think about N equaling the number of claims data systems in your environment, adding the Medicare's list makes your complication N plus one. It just adds one more layer of complication that you don't need. It's always more complicated to use Medicare's data when you're getting a flow of claims from all of your practices. It's more complicated to use it than to ignore it. In summary, use of Medicare's list creates a tedious need to reconcile their list with each of your member practices and gives you precious little time to do it with just 1 month left in your submission season. Hope this helps. Thanks.
And thank you, Laura and Carrin, for the great questions, and thank you, Dr. Mingle, for sharing your insight with us today.
Thank you, Kyle, and thanks to you, for all of you, for your great questions. I want to be helpful. I want this to be useful to you. Don't hesitate to correct or supplement my answers. Share your experiences, ask your questions. We can be smarter together.